Good morning. My name is Mike Farrell. I'm a surgical resident at Christiana Care in Delaware. Today I'm presenting the Death Diamond, a black hole for resuscitation. Thank you all for allowing me to speak here. We have no financial disclosures. The trauma triad, or the lethal triad, consists of coagulopathy, hypothermia, and acidosis. Each has been independently associated with mortality, but in recent years it's been recognized that coagulopathy is truly the driving factor. In fact, in many patients, it can be said that a patient is not dying because they are bleeding because they are dying. There is a systemic process occurring. As a subset into the coagulopathy, fibrinolysis is also associated with mortality. In 2015, a group in Denver recognized a unique R-tag or a rapid tag pattern known as the death diamond, or sometimes in the literature as the black diamond. This is a pattern that has three criteria. First, the patient must have hyperfibrinolysis, or an LY30 of greater than or equal to 3%. Second, they have to have a time to maximum amplitude, or from when the clot starts to form to the peak, of being less than 14 minutes. And then from that peak, the time to total lysis, or when you see the curve come together, has to be less than 30 minutes. In individuals who have these three criteria, it's been found to be 100% predictive and 100% specific for mortality. The biggest criticism of this paper is that it's based on only 14 death diamond patients. So we wanted to ask three questions. First, can the previous death diamond findings be replicated on a larger trauma population? Second, can it be expanded to include non-trauma patients? And third, what are we doing about it? So we completed a retrospective single-center review from 2015 to 2018. Patients were recognized first if they had a death diamond, and if they did and they were 18 years or older, we did a chart review, looking at demographics, the mechanism of injury, the management strategy, and the ultimate outcome. And here's a quick look at our population. We reviewed almost 7,000 tags, with only 34 of them having a true death diamond. That comes to about half of 1%. So while it's a very rare finding, we'll see that it's one that's very serious and needs to be taken seriously. We had 24 trauma patients total, which again is the largest study of a trauma population to date compared to the 14 previously studied. In our non-trauma population, we had 10 patients, and this is the first time that anyone's looked outside of trauma. In both groups, our average age was around 50 years old, and we did have a higher percent of males in the trauma group. We had a 75% blunt trauma rate, and our average ISS was around 26. Looking more closely at the makeup of this population, we had 6 penetrating injuries and 18 blunt of a variety of mechanism. In our non-trauma, we had medical patients, including cardiac arrest and pulmonary embolism. We also had the surgical emergencies with ruptured AAAs or perforated viscus. Of note, we did exclude 2 patients from the non-trauma population who were receiving full anticoagulation and full lytic therapy, who were hemodynamically stable throughout the entire time and simply holding or reversing their agents. The death diamond fixed very easily, and the patient, we felt, did not have that physiologic insult and that they did not fit into the population we were trying to look at. So our outcomes. We had 100% mortality in our trauma patients. The median time of survival is only 2 hours. About a third of our patients died before our rapid tag could be fully processed. If you don't use our tag often, that's only about 45 minutes. 3 of our patients, though, survived to at least 24 hours. Our non-trauma patients didn't fare any better. We had 100% mortality with a median survival time of 7 hours. 40% died in that first hour, and 10% survived at least 24 hours. What are we doing about it? Well, 91% of our trauma patients received blood products. That other 9% were all devastating head injuries who were initially hemodynamically stable, and on imaging, we saw that it was non-survivable, non-operable head injury that ultimately went towards comfort care. 2/3 of our patients received at least 3 units of blood. I point that out because at our hospital, if you get to the 3rd unit of blood, you get a call from the blood bank that says, do you want a massive transfusion protocol? So that could have influenced some of our ratio. 5 patients require the OR or IR, but what I think is more interesting is that 80% of people do not have something that we feel can be fixed in the OR. It's not a single problem going on, it's a systemic issue. 9 patients received a repeat TAG, all of them normalized. We can fix the TAG, it does not change the outcome. In our non-trauma population, 70% received blood products, 30 at least 3 units. 4 of them required the OR or IR. 4 of them had a repeat TAG, the same 4 that went to the OR. And 3 of them normalized. Again, fixing the TAG did not fix the patient. When we look closer at our blood usage, there's a few things I want to point out here. First, this is a table that's looking at the average use of each blood product by group, but an individual had to have received some blood product of some kind to be included in this average. Between the groups, there's no difference in the overall ratio being used. When we look at our red blood cell use, though, we're seeing 10 to 20 units of blood are being used on average, and 10 to 15 units of plasma are being used on average, which to date is in a patient who has no survival. And so in conclusion, death diamonds can be seen in both trauma and non-trauma patients, and they continue to have 100% predictive value for mortality. Correcting this tracing does not seem to improve the outcomes. There is something systemic going on. And the death diamond may represent a marker of futility, but we're still looking at small populations and we still don't understand the pathophysiology of what's happening about why fixing a TAG doesn't help the patient. And until we can do that, I think we need to approach futility with caution. At a minimum, though, it certainly warrants consideration in any goals of care discussion. And with that, I'd like to thank my team, and I'll take any questions.